Let's have a conversation about healthcare, right? And this is what a conversation that we've had constantly for the last 1.5 years or so because of COVID and because COVID now brings this conversation to the fore. We have talked about many things. We have talked about financing our healthcare, the Big Four agenda, and the plans of making everybody have access to healthcare. We've talked about the budgetary allocations to the health docket. We have talked about the Abuja Declaration and what our government, among others in Africa, committed themselves to doing so that it can finance healthcare in this continent. We have even talked about devolution and the effect that devolution has had on healthcare and the provision of health services. All those things. Have we actually moved or progressed anywhere in terms of increasing access to healthcare for our people? And this is one of the SDGs. Have we moved anywhere? Are we actually progressing? Is there policy, legal framework, regulations, programs that are taking us towards nirvana?
There. Everything on that particular list you've mentioned exists. The only thing you can't legislate is the will to actually ensure that these things are implemented as they were intended to. And oddly enough, when you look at our healthcare system, down memory lane, if you go into history, there was a time when you could arguably say that the system actually worked. And all the supporting units and systems around it worked. And then what has followed over time, and part of the reason why this discussion becomes pertinent, is the slow but very sure deterioration of that very system, where you are not really certain as to whether it is referred to as a healthcare system, but whether the healthcare that it's expected to dispense will actually be dispensed.
Well, we'll get there.
Yes.
But let's talk to people who are actually very keen on observing this and also participating in what is currently the management of our healthcare system. We're joined by Ibrahim Alubala, who is a child rights governance advisor and an advocate of the High Court, working for Save the Children Kenya. And we're also joined by Dr. Mohamud Aidan Mohammed, that is Mohamud Aidan Mohammed, who is the CEC for Health in Mandera. Good morning, gentlemen.
Good morning.
It's good to have you, and thank you very much for speaking to us. Welcome to the Situation Room.
Thank you. Thank you very much, and thanks for having me here.
I'll start with you, Dr. Mohamud Eda, and you work as the Minister in charge of Health in Mandera County. So let's just start with that. Is devolution actually helping us increase our healthcare provision in the country?
Thank you very much. I will say absolutely yes. When you look at everything health in terms of all the building blocks of health before devolution and after devolution, you realize that everything is going towards positivity. For example, I'll just take a few things. When you look at the question of access to health facilities, and I may take a case example of Mandera County, which is a very vast county of about 25,000 square kilometers. We had 33 health facilities overall, and today we have got 90 health facilities. When you look at the human resource, we had 154 total healthcare workers for a population of about 1.2 million in Mandera. Today we have got 1,450 healthcare workers. When you look at services that were hitherto not available in terms of specialized services, this is there. And so across the supplies, of medical commodities is more stable, more predictable, and more regular now. So overall, I'll say when you look at every facet of what constitutes health, then there's a general improvement from pre-devolution years to the current.
Is that at the pace that was really anticipated at the onset of devolution, or has there been, a slowdown in terms of implementation of all these changes?
From the beginning, when you look at the county government and how they came into existence through the 2010 constitution, and before that, For example, I'll just take the financial commitments of the county government from 2013, and specifically in the health sector component. You realize that a lot has been invested over time from 2013, 2014 to date. For example, in Kenya, 2012, 2013, just 1 year before devolution, the healthcare allocation budget was about 6.2%, that is around 94 billion. Now, when you come back and, in 2013, 2014, there's a little bit of decline, which was expected because devolution was taking off. There were prioritization of, trying to set up the infrastructure. So the allocation dropped to about 5.5, which is 78 billion. Up to today, you realize, let's say up to 1920, we are at 217. So there has been gradual increase in budgetary allocation, which will also, naturally translate to better services and better access to healthcare. So this is anticipated for the county government, yes.
Okay. As we continue to look at, questions surrounding Mr. Alubala, where the interest then is, or willingness to actually do something about making these numbers make sense. And if we're looking at a minimum of 15% when it came to what countries should be able to do for healthcare within their borders, are we looking now at ability, or are we looking at willingness then when it comes to making sure that funds are available for healthcare around counties? From your experience and what you have seen, is there an interest in saying, okay, now we're struggling to get the funds, or is it that, all right, we can deal with it later?
When you look at the perspective of where we were at independence, the allocation of health budget to health was about 9.6%. And at that time, health was free. Along the way, things changed and fees were introduced, and the budget was revised downward. But, the Abuja Declaration, like you correctly say, the African countries committed to 15% allocation of, national budgets to health. In terms of where we are as a country, I would want it to be segregated, the county government and the national government. The commitment has been there from the Kenyan government over time to increase, because we have not reached, that 15% commitment. Obviously, because of two things. Number one is political commitment that is required, and two, resource availability against so many other competing things. But generally speaking, when you look at 2013-14, we were at 5.5 in terms of allocation. Then 14-15, we are at 7.5. 15-16, around 7.7%. 16-17, 7.8%. 17-18, about 8.2, then 18-19, 9.2, and currently around somewhere around 10. We have not reached that goal, but the commitment is there from the national government and the county government, so that when you look at the county government, out of the total budgetary allocations, you realize across all the 47 counties, health is the one that is actually receiving most of the budget, takes to around, a mean of about 27.2%. So, yes, political will is required, and yes, we need to refocus against the competing interests. But yes, the will is there.
And Ibrahim, from your experience, what have you seen over the years? What have you seen, and how have things developed? How have things developed or progressed?
Thank you very much. And I think I echo what Dr. is saying. That we've seen a lot of political commitment over time. Remember when Kenya enacted its new constitution in 2010, the general feeling was that we needed to devolve things that really mattered to the common wananchi. One of the things that really mattered to the common wananchi was actually healthcare, provision of healthcare services. What we essentially call socio-economic rights was very key to the local citizens. And you remember there was always this conversation around why would someone sitting in Takaba in Mandera County, have to, bother Nairobi all the time over certain things. And so the general conclusion was that we need to devolve functions that really, really matter to the local citizen, and healthcare was key among them. So health is largely devolved, and that's why we see county governments having an expectation in terms of delivery of health services. And like Waziri has said, if you look across all the 47 counties, the bulk of the counties actually allocate a lot of, the bulk of the budgets actually go to healthcare services. Most of the counties are anything around 16 to almost 32% of their budgetary allocations on health, and that is just county government. Now, going back to what you mentioned, the Abuja Declaration, in 2001, African countries made a commitment that they were actually going to allocate close to 15% of their budget line towards health. And the reason was very clear. The realization was that most of the healthcare aspects around the fight against HIV, tuberculosis, and malaria, but most of them were actually donor funded. And there was this general belief that at some point, donor funding is not sustainable. There is need to tap into our local revenue to actually finance our health budgets. And that is why there was that commitment that 15% of the budget should be dedicated towards health. But like you've said, 20 years down the line, we've not seen a lot of African countries actually living to that expectation. I think Waziri has given a very elaborate position insofar as Kenya is concerned. We haven't hit the 15% cumulatively, but I think it's something that needs to, a commitment that needs to be realized so that we achieve our health outcomes. County governments have, the advent of county government and devolution has really helped us as a country to, soldier towards hitting the 15% mark, but we are not there yet. So yes, we've seen some bit of political commitment in terms of allocations, but we still have a lot of challenges in terms of the actual absorption of some of these resources. We know that there have been leakages, or rather reports of leakages, and so the focus also needs to move from allocation to actual utilization, so that beyond us hitting the 15% Abuja Declaration, we also need to begin also looking at how is this money that has been allocated being utilized. Thank you.
Waziri, I want to address this question to you. You said the population of your county is what, 1.2 million?
Yes, they are.
Thereabout. Now, are they predominantly rural folk, or are they predominantly urban?
They are predominantly rural.
All right. Now, from a medical perspective, you as a doctor, would you say that the preventative approach to healthcare as opposed to the curative, which of the two would you say is cost effective and which one is easier to manage?
Absolutely, the preventive and promotive component of health is where we need to put all our energy and all our resources, a lot of our resources. Currently, actually, the reverse is true. When you look at Kenya overall, we really zero down on curative services, which is, offered at level 4 and 5 and 6 facilities. Now, most of these diseases that are being managed in, level 4, 5, and 6, a lot of them will have been preventable issues or fairly well managed in terms of their complications, making patients come to level 4, 5. If only we will have invested a lot of our energies, in the preventive and promotive component. I want to give you a few examples. When you look at Kenya currently, the biggest problem that we are having is non-communicable diseases. We are having a very rapid rise in diabetes, with all its attendant complications. We are grappling with hypertension, we are grappling with cancer. Now, when you when we invest a lot of our energy in terms of educating the masses how to, first of all, prevent getting into that, state of diabetes in terms of the environmental component, the trigger, then we'll have prevented a lot of people going over into, being over diabetes. The same for hypertension. And even when you look at cancer, if only we have, invested in a lot of health education in terms of telling people what are the carcinogenic things that they need to avoid. And then we put policies in place to make sure that industries and food and everything complies with, the public health preventive component. And also we zero in on, early screening so that, these things are available in every county. Then people are told, please come without even, necessarily having the disease, you can come for routine, screening. So as much as we are concentrating on curative, the best approach is actually to zero down in preventive and promotive health services, which right now is not happening, but the national and county governments are cognizant of that fact, and they are slowly towards that direction.
Dr. Ari, I like what you've said because it's like you've gotten to answering the question I was going to ask. Most counties in this particular country of ours have a population that is predominantly rural. Why is it then that the healthcare practitioners and those in charge of policies of health, why don't they focus on this aspect that would clearly make their lives easier? Why?
Number one, I think it was a question of policy prioritization. This was not initially the main focus, but now it is turning, to be the main focus. Most of the counties after they have come into being have been trying to struggle with the question of, improving access to health, facilities itself and setting up health infrastructure. I give you a case example of Mandera, where we had only 33 health facilities before devolution, and now you can imagine how many kilometers someone has to walk to even, first of all, find, one health facility, or even, there are things that get hold of you acutely. So the counties have been, trying to expand the health infrastructure. A lot has happened. Policies are slowly changing. And you also realize that most of these level 4s and 5s deal with complications of what should have been avoidable in the first place. Mm-hmm. And these are complications if you do not have the necessary facilities in place at that point in time. They are quick killers. For example, somebody with a kidney failure will require dialysis. If that is not available at a level 4, then it will be better, or you will have to refer this person to another county or maybe to Nairobi. So initially we have been struggling with the question of setting up infrastructure for, managing a life-threatening situation. But now slowly we should actually be going towards, the preventive and promotive components of health, which is to avoid patients coming to level 4 and 5 in the first place, so that we deal with issues at level 1, 2, and 3 facilities.
So what would you say, Ibrahim, would be the best way then to approach the issue of, having a resilient health financing system in the country? Is it allowing the counties to borrow directly? Is it talking about seeking financing directly at the county level? What is the best way to approach this?
I think a couple of things need to be addressed at the same time. One is we've had a lot of complaints from county governments around exchequer disbursements, particularly from the national government. We've seen a lot of delays in terms of money hitting county funds, and that has really compromised, provision of healthcare services at the county level. So one of the key things that we probably need to be talking about in terms of having a conversation is timely disbursement of funds to our county government, so that we don't have these delays that we've kept on hearing, that where counties go for a couple of months before they actually receive their money, and that really complicates provision of health services. Because counties, we've seen, a lot of labor-related aspects, particularly from our health workers at the county level, delays of salaries, procurement of commodities. We know that quite a number of counties have not been able to service, to pay their procurement from, KEMSA and so forth and so on. So one of the key things has been around exchequer disbursements from the national government to the county government. The other thing that we probably need to be looking at is supporting our county governments to be able to generate what we call own source revenue. And this is something that we captured in the report that you cited. Because in this report, you're actually looking at two counties, counties that have done very well in terms of provision of healthcare services, and this was Mandera and Nyeri counties. And so what we are saying here is counties need to, do some sort of revenue mapping so they can identify potential revenue sources that can, boost their revenue. On average, most of the counties actually rely on upwards of up to about 80% of their county budget being funded, by the national exchequer. And when we have some of these delays that I've talked about, and in line with what we're also experiencing with the global pandemic, revenues even at the national level have dwindled.
Yep.
And so it becomes very difficult, even for the national government. So county governments need to also look inward and look at what we are calling on-source revenue. Do a revenue mapping. If you look at the constitution, county governments are expected to collect taxes in the form of property taxes and entertainment taxes. We know that most of our marginalized counties, and certainly Waziri might also want to touch on Mandera, for example. Property taxes, they might not have a very solid tax base in the sense that they might not be able to collect a lot of revenue from properties, seeing that most of the land is actually communally held. So we're also working with some of these counties to ensure that they increase their own resource envelope so that they're able to also look at certain things. And then the third thing that I would also probably talk about is around public participation. We know the national value, both at the lawmaking process, development of policies, legislations, plans of action, ensure that the public is robustly involved in those developments. But most importantly, when it comes to the budget cycle, we should ensure that the public is also meaningfully engaged, because the public knows some of their priorities.
Yep.
They should be given an opportunity to shape, the public discourse at the county level, so that some of their priorities are actually taken on board. And this is when both medium-term plans are being developed and also the annual plan. The county integrated development planning process needs to,
be more inclusive.
Yes,
and involving of the public. Well, thank you very much, Ibrahim. Ibrahim Alubala is a human rights advocate and is also a child rights governance advisor for Save the Children. And we've also been having a conversation with Dr. Mohamud, who is the CCM for Health in Mandera County. Gentlemen, thank you very much for speaking to us this morning, and we wish you a great day.